Welcome to AETCM, the emergency medicine. It's a case of 40-year-old male with no comorbidities came from outside India, presented to ER with complaints of fever, myalgia for past 15 days. Post fever, for the past 10 days, that is 5 days after the onset of fever, patient started developing multiple papular rashes all over the body. So initial 10-second assessment, patient was conscious oriented with the airway patent, with able to complete full sentences. There is no stridor, hoarseness of voice. The breathing wise, respiratory rate of 20 per minute with a saturation of 99% in room air, bilateral air entry present. Circulation wise, pulse rate of 99 per minute with a BP of 136/90 and S1 S2 heard. Disability GCS is 15/15 with a GRBS of 150 and patient was afebrile to touch. So in sample history, patient is a no-comorbidities patient, came from outside India with a history of 15 days. For the past 15 days, patient is having fever. Okay. This fever started as myalgia. Later, patient developed fever and along with back pain and sore throat. 5 days after the onset of fever, patient noticed to have small vesicular lesions. Later, it became pustular with umbilication and crustaceans was also formed.
Where it started is very important. There will be a pattern for each type of viral disease.
So, for this patient first noticed a lesion with crustaceans in his penile region. Okay. Later, it developed all over the body. Okay. He can't specifically say at what area it started. Okay. He told
area it started, then spread all over. Chickenpox starts at which area?
At the extensor area.
Chickenpox normally
start in the abdomen, thorax, then truncal, then this lesions. Then patient visited outside hospital and for further evaluation they came here. On further sexual history, patient also gave a history of unprotected sex with an unknown person. Before, like 2 weeks before the onset of fever. So there is no loose stools, vomiting, cough, breathing difficulty, abdominal pain or dysuria. Then on local examination, the lesions were pustular lesions, like it have different morphologies. Some were pustular, some lesions were pustular with umbilications and crustaceans in between. Okay. Like scabs were also there. Okay. Mostly these lesions were all over the body, mostly on the face and also on the palms and extensor aspect of the body. So adjuvants to primary survey, we did the CBC CRP point of care with a total counts of 9.9 with a CRP of 69.5 with a platelet of 204 and HB is 13.3. In VBG wise, there is no acute acid base disorder and electrolyte seems to be normal, in normal range. So since we
So what are the personal protective gears you used?
Yes. So
is it required or not?
Yeah, yes, sir. Since the patient came on the primary examination of patient, we were using facial mask and patient was also using facial mask and we isolated the patient in our isolation room and then personal protective equipments were also used by the staff who was in charge of the patient in ER.
Okay. So this type of lesions can spread either through nasal route or through hands.
So with our history and the patient history and physical examination and the lesion, we came to a diagnosis of a suspected case of MPox. Since this doesn't look like a vesicular lesion that is suggestive of herpes or chickenpox. It's more like a crustated lesion and history was also more suggestive of MPox. So we isolated the patient as well as protective gears were applied.
Which is more contagious, chickenpox or MPox?
Chickenpox is more contagious because chickenpox have respiratory droplet transmission. But MPox is more commonly with close contact as well as by the fomite transmission. So this patient, we given a dermat consultation as well as an infectious disease consultation, and we send off all the basic blood works, including VDRL and other sexually transmitted disease panel were given. Okay. Along with, we took a swab, nasal swab and throat swab as well as skin lesion swab, and sent it to the virology lab. Okay. And
VDRL is negative.
VDRL is negative because
HIV is also
HIV, all serologies came out to be negative, including syphilis was also negative. And our test result, that is virology result, came to throat and skin lesion positive for MPox. So this is a case of monkeypox or MPox, previously known as monkeypox. Now it's called as MPox only. So this is caused by a orthopox, like that is a DNA virus. Same as the same group as smallpox, that is variola, as well as smallpox vaccine, like Vaccinia group. Basically, it is two strains are there, that is Clade 1 and Clade 2, mostly seen in African subcontinents, where Clade 1 is Congo Basin, which are 1A and 1B, as well as Clade 2 is West African, that is less virulent, 2A and 2B. Highly propagation of disease is more through close contact. By in our case, there is sexual contacts. High risk of sexual behavior are more risk patients. So there is smallpox since variola is also a same group. Smallpox vaccines give some protection against monkeypox also. So after eradication of smallpox, this monkeypox become more prevalent. Then transmission is like human to human by direct contact from the infectious sore or the swab or body fluid. Close contact is most commonly transmission. Then indirect contact through fomites, that is the patient using substance. When we also come to contact with that substance, we can get that disease. Or vertical transmission also there. Pregnancy, baby congenital MPox is also documented. Mostly if congenital is there, mostly pregnancy loss or congenital infection is most common cause, but which are very rare only.
Is it dangerous before first trimester or second, third?
Actually, this is under, they haven't specifically told it. It's like under a study only. Most people will have pregnancy loss in the first trimester. Most cases, the transmission occurs when the patient is already asymptomatic patient, or some cases there will be before symptomatic also transmission can also occur. The time from onset and viral clearance is mostly 40 days. So infection can be either systematic infection as well as local inoculation, that is by the microabrasions. Through microabrasions also a virus can get into our body and we can cause infection. So then clinical features, there's a incubation period of 5 to 13 days, that is a range of 44 to 21 days into incubation period is there. Post which patient can cause with started with systemic illness like fever, chills, myalgia, and after 1 to 5 days of systemic illness, lesion can also occur. Some patient, these lesions first started in genital, anal or oral region without any systemic illness. Then the specification of this lesion is lesion will have 1 to 2 days before or 3 to 4 days after the onset of systemic symptoms, and which can continue up to 2 to 3 weeks. There is a demarcation, like first it will start as a papule, then it becomes vesicles, then it becomes pseudopustule, because it is not filled with pus, it is debrites that is filled in that thing. Then these lesions are circumscribed with deep-seated umbilicated lesion, and crusts are also there. Crusts later dry off and fell off in 7 to 14 days after the rash began. These rashes also develop simultaneously and evolve simultaneously. There is no different morphology in the same patient. Then These rashes are painful rashes, and after crusting stage, it can cause itching.
But
Then
this patient had no pain.
no pain. This patient doesn't have any pain. Then histopathologically, we can see epidermal acanthosis and spongiosis with exocytosis. Then this location of rash according to clodes. Clodes are actually strains, different strains. So in clode 1A and 2A, this is widely distributed, but in clode 2B, it's mostly anogenital monkeypox. In complication of monkeypox include proctitis and tonsillitis, ulcerative pharyngitis. Ocular complications include conjunctivitis, blepharitis, periorbital cellulitis. In some patients, it can cause encephalitis, then secondary skin infection, pneumonia, sepsis, myocarditis, parotitis, epiglottitis. All this are more common in immunocompromised patient than immunocompetent patient. Usually in immunocompetent patients, monkeypox is self-limiting with symptoms lasting for 2 to 4 weeks. For 2 to 4 weeks, we have to isolate the patient. That's the support treatment. In lab-wise, there will be abnormal OTPT could be there, leukocytosis, thrombocytopenia. In some patients, there will be hypoalbuminemia due to exposure of skin, and dehydration can also occur. And diagnosis wise, most probably we use PCR for orthomyxovirus DNA. Either swabs we'll take from the skin or throat, blood and can also be used. Through swabs, we use 2 swabs from each specimen we will take. And there are other tests include anti-orthopox virus IgM antibody can be used, which is an ELISA test, which will be positive 4 to 56 days after rash. If there is IgM IgG, it suggests that there is faster viral clearance and good prognosis. And some places we also use
all IgMs will be positive only after 1 week of the disease. Why it is like that?
IgM will take 1 week to produce.
Antibodies. It will take some time to develop in our body. Okay. High titers always indicates high immunity.
Then electron microscope also can be used, where we'll see brick-shaped pox virus can be seen. But mostly in India we use PCR only. Rest everything not there available.
And it is not commercially available. It's only in virology labs you will get.
And there are subclinical and sometimes asymptomatic MPoxes, which are very rare, but patients are highly infectious. Management include supportive management, pain management, then prevention of dehydration, secondary skin infection, we give antibiotics. And antiviral therapy can be used in immunocompromised or severe disease in pneumonia and encephalitis. Mostly used antiviral is tecovirimat, which is a potent inhibitor of orthopox virus, which we usually give is 600 mg over 12 hours for 14 days, which is not that available in India. Then other thing is we have to identify the case, isolate the patient, patient protective care we have to give, and patient consider infectious till all lesions, all scabs fell off and re-epithelialization of occur. That is approximately 2 to 4 weeks patient will be infectious. So for 4 weeks we have to isolate the patient. If we get exposed to such a patient, we have to monitor ourselves for the next 21 days. If we develop symptoms, we have to isolate ourselves, and after symptom development for the 5 days there is no symptoms or no lesion, we can de-isolate. If symptoms develop, we have to isolate for the next 4 weeks. So if even after recovery, we have to use condoms for sexual for the next 12 weeks after de-isolation, because the virus having more tendency to stay in semen and genital fluids. Then there are vaccinations available for MPox. There are 2 types of vaccinations available, which will only reduce the risk of developing MPox. Most commonly used is modified Vaccinia Ankara vaccine, MVA vaccine, which can be given after 18 years of age. Which is
available in India?
No, sir. Vaccines are not that available in India. There are live vaccine, which are non-replicated smallpox or MPox vaccine, which are mostly available in USA European Union and Canada, which is an excellent vaccine. We can use 2 doses 4 weeks apart can be used. And there is another vaccine, AETCM 2000, which is only used in selected patients, which is a replication competent smallpox and MPox vaccine, which is not that used. So pre-exposure we can use vaccine, and post-exposure in a vaccinated patient, post-vaccination is not that indicated. We will observe the patient and monitor the patient. For travelers to indigenous MPox indigenous area, we can give MPox vaccine at least 6 weeks before traveling, because after 2 doses they will take at least 14 days to develop immunization. Post-exposure also, vaccinations can be given for people at risk. Otherwise, we can, and MVA is the recommended vaccine. We can just monitor. Alternative to vaccination, we can also use Vaccinia IgG, which is the immunoglobulin, which is also used only in highly immunocompromised patients. Mostly in India, since we doesn't see that much amount of MPoxes, we will just symptomatically manage with antiviral if in high.
What is the treatment given for this patient? For this
patient, we sent to virology lab. It came out to be positive. We started on supportive management. We started with IV fluid, painkillers, other skin therapies, and also started on antiviral. Valcyclovir was being started.
What painkiller is it?
PCM, paracetamol. Our patient doesn't have that much of pain, so
okay.
PCM for pain.
Anything else you want to add? Nothing. Okay. Thank you.
Thanks.